Hi, everyone. Thank you for joining us. I'm Katie Sacra, GFPD Director of Family Programs. I'm also mom to an adult living with PBD-ZSD, and I'll be moderating tonight's GFPD webinar, Considerations for Managing Hearing Loss and Peroxisomal Disorders. Joining us today is Dr. Meredith Holcomb, Associate Professor and Director of the Hearing Implant Program at the University of Miami, Department of Otolaryngology. And with that, thank you so much for being with us today, and I'm going to hand it off to you.
Thank you, Katie, and thank you for all of you who are listening. I feel very honored to have been invited to speak to this group. I've also been extremely honored to be the managing audiologist for Katie's son for several years in South Carolina. We'll talk about TJ at the end of this presentation, but he really changed my perspective on hearing loss for children who have other things going on besides just the hearing loss. And he really made me think about how to manage children with hearing loss differently when hearing loss is not the only thing that is prevalent for this child and this family. I'm the director of the Hearing Implant Program here at the University of Miami, and I strongly believe that it takes a very large team to appropriately manage children with hearing loss, and especially children who have or who are multiply involved. You can see from this slide, we have an enormous team of professionals at the Hearing Implant Program at the University of Miami. We believe very strongly in multidisciplinary care. We're fortunate enough to have probably one of the most diverse groups of people to address hearing loss in children of any team that's out there. We are lucky enough to have two pediatric psychologists. We have multiple speech language pathologists who speak more than one language. Most of them do. We have an educational specialist that's assigned to our team, and she also works part-time at Miami-Dade. And Miami-Dade is one of the biggest public school system in the US. We have a social worker who not only works with our children, but with our adults and a lot of our children who are transitioning to be adults. And then we have a large clinical support staff as well, who is instrumental in answering phone calls and making sure that messages from parents and from caregivers are appropriately and timely relayed to the audiologists and the physicians. So it really takes a whole team. I believe strongly that there is a very large village around children with hearing loss, particularly children who are multiply involved. If you look at this, you see lots of different individuals who make up this village, but at the center of the village is the child, and the parents and the family and the caregiver really are one of the most important aspects of this team as well. One of the things I think sometimes gets maybe in the way or overlooked with children who have other disabilities besides hearing loss is what the parent sees at home. And I always tell families, I have trained very hard and have worked for 16 years trying to manage hearing loss in children, but I don't have a child, and I certainly don't have a child with hearing loss. And I don't have a child with hearing loss and other things that are going on as well. And so parents, you live it every day. Caregivers, you live it every day. And if you have providers who aren't appropriately listening to you and taking your opinions and your viewpoints and what you see every day, if they're not taking that into account, I would strongly encourage you to find a good team who will listen to you. You all know your children better than anyone. I think all of us know, we're well versed in the fact that hearing loss should be identified early, and treatment of hearing loss should be identified or should be treated early. There's multiple benefits of treating and identifying hearing loss as early as possible. Spoken language development for some children is a huge benefit, but not only spoken language development. And I think that's something we get caught up in too much, and we really have to think outside of that for children who that may not be a goal. Communication in general is extremely important for children, for families, and that also comes into play for social interaction with siblings, with other family members, with other children at school. Literacy and learning is strongly attached to early identification of hearing loss. And then, the earlier we can identify exactly what the child's needs needs are, we can appropriately figure out what special ed programs are needed for the child, instead of wasting a lot of time on putting them in education programs that maybe are not suitable for what that child needs long term. I think many of you probably have been involved in those IEP meetings that can be quite laborious and painful and frustrating at times, and really taking a look at the whole child and identifying exactly what is necessary to foster their growth and foster their academic success is a huge key point for the overall success of your child and you guys as parents. I think sometimes we think about hearing aids as just being a quick fix for the hearing loss. Let's get hearing aids fit as quickly as possible. But more than that, we need to make sure that hearing aids are being fit appropriately. And this requires, in my opinion, a specialized pediatric audiologist who is very much well-versed in pediatric hearing loss, how to manage pediatric hearing aids, how to appropriately fit them, and then also how to assess whether or not those hearing aids are appropriate long-term for the child's hearing loss. This is a really cute picture of a little one who is sitting still. Maybe we have the assistance of an iPad or even an iPhone now. They make great test assistants and hearing aid fitting assistants for our clinics. But it does require a little bit of effort and extra work to be sure that the child is hearing appropriately with the hearing aids. One of the things that's been interesting in the past few years, and I do work with a lot of children with cochlear implants, we have looked at research and found that even just by fitting hearing aids on infants who can't tell you how much they're hearing, we're able to use that information, which you can see on the right is a screenshot of what we're looking at as audiologists when we're fitting hearing aids. We can use some of this information and some of the numerical values that show up on this testing to quickly assess whether or not a child is going to benefit enough from a hearing aid or whether or not they may need to be referred for a cochlear implant. I've been, like I said earlier, doing this for 16 years. And in the first probably decade of my career, we didn't have as many of these evidence-based tools to make quick recommendations about referring children for cochlear implants or for other technology. And so oftentimes children who had special needs or were unable to tell us what they were hearing with their hearing aids, or even unable to really cooperate well enough in the sound booth for testing, those children may have been delayed in getting the appropriate care that they needed solely because we as professionals weren't really sure when to refer those children on for further assessment for cochlear implants. But I'm going to show you a few things that we've learned along the way. And hopefully if you have a younger child who's in the process with hearing aids, you can take some of this information and share it either with your audiologist or, just use this as a talking point with your audiologist about the appropriate care for your child. We think about children not progressing with hearing aids, and I know with a lot of the disorders that your children may have, similar to TJ, oftentimes they may have some hearing loss in one ear, some hearing loss in both ears, a lot of hearing loss in both ears, or no hearing at all. Lack of progress with hearing aids, it can be due to a lot of things. And so some of the things I think we have to think about as professionals and as family members are considering the technology. Are our children really fit appropriately with the best hearing technology? Are the hearing aids turned up loud enough? Are the hearing aids being fit by pediatric audiologists who have the special skills and knowledge to work with your child? The professionals, are the professionals involved in your child's care and on that team, are they well versed in the syndromes, in the other involvements that could be going on with your child? And then we also, as providers, we have to consider the child and the family. Not every child progresses with appropriate amplification the same way. Similar to not every child talks at the same age. They don't crawl at the same age. Many things are very different depending on what all is going on with the child. Sadly, there are some times where the family may not be able to follow all the recommendations of the providers, or, health literacy is a very big concern down in Miami. We have a lot of low health literacy with some of our families, and that's not necessarily anyone's fault, but it means that we as providers need to make sure we're doing the best we can to almost, sort of cheerlead families so that they can be the best advocates for their child. And even when all of these things are in the right place and everything is, as you would want it to be for your child's hearing loss management, there's still a lot of red flags about hearing loss and why hearing aids may not be enough. There's a lot of boxes here, but one of the main boxes is that multiply involved population. If you have providers who are not accustomed to working with children with different syndromes or cognitive delays or speech delays that are more involved than just the hearing loss, some of these things may be overlooked, and even though children may not be responding well with hearing aids, it may take a while to get to the next appropriate technology. Some of the factors that we do see that affect hearing aids greatly in the success of hearing aids are listed here. And you can see this is a huge compilation of different factors. Anything from the degree of the hearing loss to maternal education level, financial resources, the number of hours that the child is wearing the device, all of these things are factors that can affect whether or not your child or the child you're caring for is successful with hearing aids. We start thinking about cochlear implant candidacy when we find that children are not progressing or flourishing with hearing aids. Perhaps families are saying, I just don't feel like my child is responding to sounds. I feel like when I'm talking, their face is not lighting up. Some children can't turn their heads to the parent's voice, but there are reactions that you can look for. Now, in 2023, there's lots of ways we look at considerations for cochlear implant candidacy, and it's not all just about the hearing loss anymore. It's more involved than that. There's a lot of things that we want to ask questions about: what technology will be best, what kind of history the child has, how involved they have been with therapy, what medical considerations do we need to be careful of? Is that going to delay the surgery in some aspect? But ultimately, we want to address the hearing loss and we want to make things better overall. It's not always the outcome that speech recognition and speech perception and oral spoken language is going to be the goal, but the goal should be overall improved quality of life, improved safety, knowing, just that you're hearing sounds, and improved communication and social interaction with family members. This is a little bit of an involved slide. It's an audiogram, and most of you probably know what this looks like, but just to review, from the left side to the right side is like a piano scale. So if you think about low pitch notes all the way to high pitch notes. From the top to the bottom is intensity or loudness of sound. So super, super soft sounds at -10. 120 is as loud as we can go with our machine. And that's pretty similar to a rock band playing in your ear for someone who has normal hearing. This is looking at the candidacy for adults and for pediatrics. So for adults, you can see there's a huge kind of range. In that orange range, we go from moderate hearing loss all the way down to profound hearing loss. But when we start looking at pediatric candidacy, it gets a little bit more confusing. And unfortunately, even though these implants have been approved for pediatric use since the 80s, only since 1998 have they been approved for children who were prelingually deafened, meaning children who were born with hearing loss. And if you can believe it, the candidacy as far as the hearing loss hasn't changed drastically since that time. So on label or FDA criteria still says that children who are a year now 9 months, actually 9 months to 2 years. They have to be in the profound range. So basically no hearing or very little usable hearing in both ears. And then when we get to 2 years and up, we get a little bit better hearing loss that we can incorporate into that FDA on-label hearing, but it's still severe to profound. And that means that children have to have, basically little usable hearing. Maybe they can respond a little bit with hearing aids, but it's not likely that they are responsive to very much speech unless it's a very loud sound or a grandpa's voice who maybe is a boisterous voice, but they may hear more like clapping and loud toys. To make it even more difficult, children who are qualified technically for FDA Pediatric CI Candidacy, they are only allowed to get 30% or less words correct when wearing their hearing aids. So this has not really evolved at all in the past couple of decades. And when we look at children who have maybe a little bit better hearing than severe to profound, that's what we consider off-label. And even children who are multiply involved for a long time were considered off-label because I think providers didn't really know what the outcome would be. Because we were looking more at speech improvement and speech perception outcomes. I think that made us as providers feel better because we could tangibly have like a numerical value to say, oh, look how successful this child was with getting a cochlear implant. And of course, over time, what we know is that really does not have a huge bearing anymore on who should or should not be implanted. Unfortunately, there are a lot of cochlear implant clinics out there who don't work with kids often enough and specifically do not work with children with syndromes or other involvements on a routine basis. So what you may find if any of you go to these clinics that are not as well-versed with working with your child, they may be sticking to this very strict criteria, even though your child needs to have better hearing technology than hearing aids. So when we think about anything that's outside of what I just talked about, it's called off-label criteria. And off-label criteria is really more common now for a lot of configurations of hearing loss. Almost 80% of CI surgeons are performing off-label CI surgeries, which is great news. And there's a growing number of pediatric CI cases for these non-traditional or off-label candidates. And we see a lot of positive outcomes, especially with improved speech and language, but also with quality of life. So in the past, it was very simple looking at pediatric cochlear implants and who maybe wasn't benefiting from hearing aids. And now we know that children are extremely complex, and so should be the cochlear implant process. So lots of different individuals who make up that village that we talked about earlier, who can play a positive role in your child progressing from hearing aids to cochlear implants. One of the things we do look at is we do an aided assessment, and that oftentimes will be some of those measurements I was talking about with putting something in the ear while your child is wearing a hearing aid. For children who can't do testing in the sound booth, just doing that testing with the machine that you see on the left should be sufficient enough to know whether or not the child is getting a sufficient benefit from a cochlear or from a hearing aid. We also have different tools that we can look at auditory behavior and know whether or not your child is responding appropriately to sounds and how they compare to a normal developing child, and whether or not that delay or that difference between a normal developing child and a child with delays, whether or not that's something that a cochlear implant could help with. For children who have spoken language, we can also use aided speech recognition to assess this too. So overall, we have lots of different tools to look at whether or not children can progress from hearing aids to cochlear implants, and it doesn't necessarily mean that they have to be responsive in a sound booth, and it also doesn't mean that they have to verbally be able to tell us that they're not hearing certain things. One of the biggest things I see on here is where it says parents express concerns or frustrations with child's development of auditory and or communication skills. And again, that's where I think we have to go back and really pay attention to what parents are seeing at home and how they perceive the child's benefit or lack of benefit with hearing aids. There's lots of reasons why there are outcomes that will vary with cochlear implants for children, and you can see many of those listed there. Some of them are anatomy, cognition. They could also be syndromes. They could be history of hearing aid use. And then post-operatively, we see a lot of reasons why outcomes would vary as well. And that would be, again, anything from programming parameters, making sure you have a good audiologist, consistent CI device use, whether or not the surgeon gets the device in appropriately. But the biggest thing is family and parent support. Interestingly enough, there was an article by a group at UNC Chapel Hill who just looked at their pediatric CI eval referrals. And what I found interesting about this is that neurotologists are more likely to refer your child for a CI eval than pediatric ENTs or general ENTs. So I say that because if you do have a child with hearing loss, pediatric ENTs, nothing wrong with it by any means, but neurotologists who are specialized specifically in the ears may be the right route for you to take, specifically if you're looking at changing your technology for your child, or if you feel like perhaps you're not being heard from who's managing your child as it is. 25% of children that they looked at in their clinic were told that they were not cochlear implants. Who were cochlear implants candidates were not referred for the evaluation because the provider, which by the way, the provider was the audiologist, assumed that the child was not a candidate. And I think, we all know what assuming does, right? We don't want to do that. But I found this very interesting because this is a huge pediatric center who works with children with hearing loss all the time. And so even in their center, there are providers who just make assumptions about whether or not your child could benefit from this technology. And older children, interestingly, are referred less often than younger children. One other thing I wanted to mention was just the evolution of cochlear implant devices and how things have really evolved over time with making this an accessible, easier way for children to wear the devices. Some children with autism, with sensory disorders, don't like things on their ears. So now we have the Kanso 2, the Rondo 3, which you can just put on the head, which has been great. We also have different types of ways of streaming the technology for iPads, for AuDCOM boards, for computers at school. And it's made all children, not just children with spoken language, but all children be able to be more accessible and more engaged in the technology that we all use every day. There's waterproof options, which are huge down in Florida. And I know Katie knows these are huge in South Carolina where she lives because children are in water a lot. I hear all the time down here, thank goodness, we have these options because it's summer every day, which is the truth. And we want children to be able to hear and make use of their surroundings and the environment that they're in, and to be able to have social interaction even in the water. We also have seen a growth in expanded cochlear implant criteria, even for children who are considered off-label. We do have a lot of kids, and TJ Katie's son is one of these children who is able to use a hearing aid in one ear and an implant in the other ear. And it's been a great bimodal condition for him, meaning he has two modes of technology, but they work really closely together to provide him the best output and the best audibility. When we think about multiply involved children, about 50% of children now have additional disabilities. And I was talking to my pediatric psychologist and my team today preparing for this. And I said, I want to use the right verbiage. Is it multiply involved? Is it deaf plus? And we both sort of agreed that multiply involved is kind of the best words to use because there's so many involvements in children we see. ADHD, ADD, sensory, disorders, learning disorders. I mean, there's just so many different things that can pop up with the hearing loss or later on after the hearing loss has been diagnosed. And we need to be very mindful of all of those and make sure we treat each of them individually, because if we don't, then we're not giving the best care for the child. The timing of the CI surgery, as many of you may know who have children who have a cochlear implant, sometimes it can be delayed due to complex medical needs. And that's just due to other things that are going on with the child, whether it's, needing other surgical interventions. Perhaps they've been in the hospital for a while. I know COVID delayed some of our children for getting surgery in 2020 and 2021. Outcomes can vary across disorders and within the same syndrome, but typically outcomes are very favorable, and we see improvements in sound awareness, speech intelligibility, language skills, communication skills, and the biggest thing is quality of life and interactions with family and peers. We have different ways of rating whether or not children are progressing in their speech or auditory performance. And these rate scales, they don't rely on actually verbally, making progress with saying words, but it's more about how they are able to use their audibility to perceive sounds and to recognize sounds. Our recommendation overall, especially at the University of Miami, is that children should be referred for a cochlear implant evaluation as soon as limited audibility with amplification is established. We believe very, very strongly in treating the hearing loss, but also looking at the whole child, making sure that we are discussing everything with the family, with all the providers involved in care, and that realistic expectations should include information about the impact of those diagnosed disabilities on the overall performance of hearing loss, and how they may play into outcomes, even with a hearing aid or a cochlear implant. So with that, I'm going to end this with one of my favorite people to talk about, which is TJ. And I don't necessarily have to educate you all on what Zellweger syndrome is. This was the first time I had ever encountered a child with Zellweger syndrome. And I was shocked by how many symptoms went along with this syndrome. And I got to tell you, I met TJ when he was a teenager. One of the things that I was most concerned about was that, the prognosis for infants with Zellweger syndrome is very poor, and often they do not survive past the first 6 months of life. And TJ had already surpassed all of these things because he was already in his teens. So this is TJ, and many of you, I'm sure, know Katie, and you've met TJ. He is a wonderful child. When I met him, he was 15. He had severe hearing loss in both ears. Diagnosed at birth, he wore hearing aids religiously. He had limited oral communication, but he did finger spelling. His mother, as you know, and his father as well are super committed to his care. Hearing aids provided some benefit. They were extremely motivated family. When they met us, they had been to several centers who had actually denied him a cochlear implant because they weren't really sure if it was going to be helpful or what he would perceive of benefit. Dr. Meyer, who's a neurologist at MUSC, and I both felt strongly that we should implant him, and for all the reasons that we kind of talked about before and the outcomes that we see with children with multiple involvement. This is TJ at his initial activation. One of the things I want to point out again is that the previous providers thought that he would not benefit or be able to acknowledge that there was benefit from a cochlear implant. This is actually the second that we turned him on, and I just want you to watch his reaction. Okay, so it's turned on right now. I'm going to keep turning it up.
It's okay, baby. You're okay.
Good job, buddy.
You heard that.
Yeah.
You hear it. So one of the things that always sticks out to me is that TJ, he searched for sound, and then he realized it was coming from in front of him. He leaned forward where I was, and he put his finger to his ear, not to the other ear, but to the ear that was implanted. I had a student with me at the time, Sarah, and I looked at each other and we were like, oh my gosh, this is amazing. I will admit we did not preoperatively test him in the booth. I think we made assumptions that he would not be able to do testing inside a sound booth. We did do an ABR that confirmed his hearing loss in conjunction with an MRI. And we even had to convince Katie a little bit to let us put him in the booth because I think she also thought that, it would not be something that he would be able to do. And we said, please let us try. Please let us try. So she, of course, said, okay, let's see how it goes. So we were in the booth. You can see Katie there with her phone. So she is his centering toy, if you will. And we educated her not to make too much contact with him, but just to sit there so he knew her presence was there. You'll see that he will turn to his right side when he appropriately hears the sound. And I want you to just watch how consistent he is with this. Bop, 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 bop. And so we're testing TJ, who's 14. We're testing him similar to what we would do with a 2-year-old down to a 6-month-old.
Bop, 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 bop.
But this was the most consistent, reliable way for him to respond to sound. He's wearing the cochlear implant. He midlines himself. We wait.
Bop, 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 bop.
And even as soft as 15 decibels, which is in a normal hearing range, he is able to turn consistently to speech. We were then able to get a cochlear implant audiogram on him. And not only that, we were able to assess his left ear, which is his hearing aid ear. And we were able to look at what he has unaided and aided in that ear as well. Now, he's not implanted in the left ear. I think Katie and her husband made a great decision to keep him bimodal. He's a lot of hearing in that left ear. And, you know, when he takes the implant off, he still can hear some in the left side. One of the things I think that's so important to talk about too, and I'm almost done, I promise, but the IPMA, which I mentioned before, is a parent questionnaire about audibility and what kind of responsiveness they're seeing to sound. So before he had the implant, he scored a 17 out of 40. And a year after he had the implant, he was at a 36 out of 40. And you can see there a lot of the differences, the increases that his parents reported, increased vocal behavior, increased responsiveness to noise and environmental sounds, and similar performance in voice discrimination, which is not too surprising, but he was better at identifying emotion. And emotion is so important because so much communication becomes carried through emotion, especially from parents to children. The other big thing that we were really excited about with him is not only did this surgery and this technology increase his overall communication, and it decreased his anxiety, but it made him excited about being in water. I love these pictures of him because with the Neptune device that he was wearing, he loved to be in water. He loved to splash around. And overall, it really improved his quality of life, which I think is one of the biggest things that we have to think about with children who are multiply involved. This is TJ, just one more quick video of him, and you're going to hear Katie giving him a word, oatmeal, and he's going to be signing to her.
How about oatmeal? Yay, did we have oatmeal for breakfast?
So in summary, you know, hearing loss is super complex, especially for children with other involvements. Candidacy for cochlear implantation is way more than just the audiogram. It's really about what we need to get children more involved in their world. You definitely need a skilled CI team to manage the whole child. And I think we have to always keep in mind that children can benefit from any hearing technology, even when they're not necessarily traditional candidates, but specifically for cochlear implants, we've got to think off label for children who have multiple involvements. And we do see significant improvements, not only in hearing, but quality of life, which I don't think can truly be measured by any kind of metric that we have for a sound booth or something that we do in audiology. But this is one of the most important things for children post-CI surgery. Lastly, we have two big resources. I think parents of children with cochlear implants, 15,000 members on Facebook. You could even type in a specific disorder or syndrome, and other people who have commented or have posted about that will pop up and you can converse with them. And then the American Cochlear Implant Alliance is also a great resource of providers, scientists, consumers, and it provides a lot of good information about cochlear implants. Thank you all so much for listening. I hope that what I said or any little tidbit was helpful. I got to tell you, I really miss Katie and I miss TJ in my practice. I have presented him in literally probably 10 countries all over the world, and he makes such an impact every time I present on him. And I'm just very thankful for Katie and for this organization that you all allow me to share his story and other stories like yours. Thank you.
Thank you. A huge thank you right back to you for sharing your expertise with all of us today. A few things that you shared, and yes, I never know what videos are going to pop up. I send lots of videos to be able to share the progress he's making, because it is so exciting to see. I love how much you, throughout the entire presentation, talked about that multidisciplinary approach. It takes a village, look at the whole child. I kept hearing that throughout your presentation. I really appreciate that. That was a huge message at our conference this past year, even for everyone to hear, and make sure that we're, this is a very complex disease. And so making sure that we treat the whole child, the whole family, and then bringing a new term to us about being multiply involved. I do appreciate that, considering we do have these deaf blindness with additional disabilities, and they're medically complex, and there are so many different terms, and I will add that to my list to use. We do have some questions. I have one that came in asking about, we are new to having hearing aids for our 13-month-old daughter. Do you have any tips to share with us as parents, and tips I can pass on to her caregivers at daycare to ensure we're supporting her so that we can get the most out of her hearing aids?
This is a great question, Sarah. I love this question. I think you are going to be the biggest advocate for your child. I had a family in South Carolina. She had a little notebook that she made, and every time her child went to a different school, a different grade, that notebook went with the child. She went in and educated the teachers, the people who were in the daycare or the school, about how to put the hearing aids back in and how to put the batteries in if they came out or needed to be changed. Fortunately, we as providers now are able to look at data logging. Data logging tells us how many hours a day the child is wearing the hearing aids or cochlear implant, Baha, any of that technology. And we're able to use that information to give to you as parents. And then you can also take that information to educate the daycare and, just talk about if your child's not hearing, then they don't have access to sound. They don't have access to social interaction, to, intonation, cues about emotion, and, how important that is. And I think most people want to be really involved and help your child succeed. So I just strongly encourage you to be the biggest advocate that you can for them.
Thank you so much. We have another question asking, are you consulting with the child's team of teachers, including the teachers of the deaf, before making the decision to implant?
Yes. So I would say absolutely yes. If the child is old enough that they do have a teacher of the deaf, then for sure we are looking at any information we can get from the educational team. We want to make sure that we check, as many boxes as possible as far as everybody involved in the team and what they're seeing. I think the educational team is so important, because once the child's at school, you guys are the ones that are seeing them 8 hours a day. There's so much information that we can get from you all. And then likewise, I think there's so much information that we can give back to you to help make the child even more successful after implantation as well.
And I can add to that as a parent as well.
Yeah, definitely.
There's an audiologist sometimes on the staff with the school, and sometimes there's not. So I think even having the two audiologists, if you do have one through your school system, communicate with the audiologist that you're seeing outside of the school system. We definitely did that, and making sure that you have current reports for the educational team. I'm a firm believer in making sure that you can get as many people on board to communicate, because that's only going to benefit the child.
Mm-hmm.
We also have another question. It's a little bit lengthy. I think you may have seen it in there.
Yeah, I can see it.
Do you want me to read the whole thing, or do you want to go ahead and
I can do it. So it's a great question. Thank you for writing this in. So this person has an 8-month-old son who did not qualify for regular hearing aids. And the reason is that the ear canals are so small that hearing aids may not have been the most appropriate technology. And so instead, the physician recommended a Baha device. And a Baha device is something that, for those of you who don't know, it's not a cochlear implant and it's not a hearing aid. It's a device that will actually stimulate right behind your ear. And it's sort of like if you put your finger in your ear and you can't hear, if you stimulated even like a kind of those headphones that they're like bone conduction headphones. You should try those if you've never tried them. This is what it does for children who have very small ear canals or no ear canals. It's amazing technology. So the question is that, unfortunately at 8 months old, babies have to wear these on a headband, which can be kind of cumbersome. It can be a little bit frustrating for the child. And, is there an option for surgical implantation? So the good news is that yes, they can be surgically implanted. The bad news is you got to wait a couple of years just to make sure that the skull is fully developed. They typically wait until about 5 years old, I believe, to do that surgery. So I would suggest making sure that the headband is tight enough, but not so tight that it's causing discomfort. Work with your audiologist about that. There are lots of different sizes for the headband. And then some of it is just getting the child in that routine of keeping it on, which I'm sure can be a little bit of a laborious task in the beginning. Typically, this is not somebody who would be a cochlear implant candidate later on, because fortunately the cochlea is working perfectly normally, which is amazing. For a cochlear implant, the cochlea is not working normally. So I think you've got great technology at your hand, and I'm excited to see how your son does in the future.
Thanks so much for taking that one on. It was a really great question. And I
Yeah.
love how you explain about the differences. So I really appreciate that. And the shout out about trying out those headphones. I have myself never done that.
Yeah.
I wanted to just share with the rest of the audience today that when you saw those videos of my son, he had never touched his ear before. So I just wanted to share that little piece when you're looking at it. And I know that sometimes you may have not have had the same experience. It may not have been so positive. When my son was first aided, when he had hearing aids, he cried and he was terrified, and it was not an easy process. We were really lucky to have a very different and positive experience when he was activated with the cochlear implant. And I was shocked myself that he touched his ear. And I'm sorry, the screen just switched.
Oh, sorry.
And so that's okay. And so I just wanted to be able to share that he'd never touched his ear before. He'd never localized at that level. That was a surprise to me and my husband. And the head turns in the booth testing that you saw, he had never accomplished that before. So know that these are things that were very new to us and were surprising to us, and that this was not an expectation that I ever thought that we would see. That we didn't even set it because we didn't think this would happen. But I also want to share that I really appreciate you just making sure that everyone knows that the criteria has changed, and to make sure everyone hears that, and that if you're feeling unheard, because I was unheard for so long, and that's one of the reasons I know that other families are not feeling heard, and that's why we wanted to have this important educational webinar tonight. And so please know that if you're feeling unheard, get a second opinion, get a third opinion, keep pushing, keep talking to professionals, and making sure that you're getting the care that your child deserves. And so the other piece to that is the communication. I want to just really emphasize that, our kids that have these multisensory impairments, they have different modes of communication. And as you heard her share tonight, they are not basing this on verbal language, and they shouldn't be. And I just really am grateful to hear that and see that on there, because that is so important for all of our families to know, that our children should not be limited if they are not verbally speaking. My own son has adaptive language. He has so many different modes of communication, from body language to adaptive sign and touching cues, haptics, and just object cards. So really just try to remember that the things have definitely changed. And there's a lot of great information that was shared tonight that can really help you advocate for your child to be able to have the best way of hearing possible. It really opens up doors, and it provides so much access to their environment. So if you have any questions, everyone should know how to reach me. If not, it's katie@thegfpd.org. I thank you all for joining us this evening, maybe daytime for those who may not be in the US. Meredith, thank you so much for being with us. And with that, I just want to thank you again and wish everyone a good day or good night, depending on where you live.